Hi, my name is Ike Brooks. I'm going to be presenting a case study. The case study is over the pelvis and the perineum. To start out with, we're going to be going over how the patient is presenting. So we have a 50-year-old man who has came to the emergency room via ambulance because he was in a motor vehicular accident. He is complaining of abdominal and of pelvic pain. He's denying any shortness of breath, and he's denying chest pain. His vital signs are 110 beats per minute for his heart rate. His breaths per minute are 22. That's his respiration rate, which is a little bit shallow. We do see his blood pressure is 120/62. That bottom number is a little bit low. And then we have also been giving him some IV fluids throughout the examination. So for our physical examination, we can see that we have a little bit of physical anatomy that I want to go over first. So here is our butterfly hematoma. You can see that's right under the scrotum and then right above the anus. And it's all in that area that we can see kind of that butterfly shape. And that's also in the superficial perineum that we're seeing that. We're also seeing some blood in the urethra. It's in the meatus of the penis. And so we're going to want to do some further testing to see what that's about. We can also see that the bladder is palpably full. We also did a digital rectal exam, and from doing that, we were able to see that the prostate was in the correct positioning. We decided not to do a Foley just because of some of the damage that we think that might occur from that. So keep that in mind. We'll come back to that point when we get into our anatomy in just a second. So to continue, we were able to do a radiograph of the pelvis to kind of get some of the fractures that we're seeing there. You can see just based off of this picture that we have 4 different fractures here, and 4 fractures on 3 different locations. And so now we're going to talk a little bit about the anatomy, kind of the bone structure of our pelvis. So this picture here, this is not related to our patient, but this was from Houston Clinic, and I thought it was a good representation of the damage that was done here. So we can see immediately that we've got our pelvic ring here. We saw that we did have a fracture right over here in this area on the pelvic ring. We can also see that our ischium on both sides had some of those, had that fracture there. And then we can also see our pubic symphysis here. That also had those fracture. And then over here on this picture, you can see kind of how those fractures are generally how they break. And so, especially this one right here, that's very similar to the fracture that we see on our actual patient. And so we're going to go ahead and we're going to continue with our physical examination. We were able to do a retrograde urethrogram. And so we did that by taking a small bore catheter and we put it in the navicular fossa of the urethra. That's right at the tip. And so it would be like we were going to do a Foley catheter, but this one is a little bit different. This one is not as extreme. We were able to put some contrast dye into the urethra for some fluoroscopic observation. We did see some leakage there, so we're going to show you here a little bit of that leakage there. That's what we're seeing. We were able to put the dye up this way. There's the bladder, and then we were able to see, oh, there is some leakage. So we're going to do some further testing on that to see what we got going on. We're also going to talk a little bit about the anatomy of that area. So we talked about the anatomy of the pelvis. Now we're going to go more into the more tissue anatomy here. So we've got the perineal membrane here. I thought this was a really good picture because you could kind of see that butterfly shape, where that membrane exists and where that pooling is going to occur. Also over here, you can see this is the navicular fossa. This is where we're going to start that initial catheter, but we're not going to do the Foley catheter because if you can see here, this area, that's where our damage is. If we were to put the full Foley catheter all the way up and it was to miss and not go into the bladder, it would cause more damage. We do not want that. We can also see here from the general area here how close the bladder is to some of that membranous urethra there and some of the spongy urethra. We can see how those two connect together there. So just wanted to point that out as part of our anatomy. Next up, we are going to start with our initial treatment. So the initial treatment was a suprapubic cystostomy. And so basically that is like a colostomy bag, but for your bladder. And so because you're not able to use your urethra, you're not able to get the urine out that way, we're going to have to be able to evacuate the bladder somehow. So our best bet is to be able to use this cystostomy. And after about 3 days, we were able to do a little bit of fixation on the pelvis. So we had those 4 fractures that we were needing to get fixed. So we got some fixation going on there. And then we were able to do a little bit better imaging because we put the cystostomy tube in. We were able to go in there and we were able to confirm that the leaking that we saw in the previous image was in fact a rupture of their urethra. There was a tear there in their urethra. So next we're going to go and talk a little bit about a differential diagnosis. For our specific case study, we didn't have a differential diagnosis simply because our imaging was so good that we were pretty certain of what our diagnosis should be. One thing I did want to talk about though, it would be the acutabular fractures. So we didn't see that on any of our pictures, but I wanted to bring it up just because in a lot of cases where we see multiple hip fractures like that from a traumatic injury like a motor vehicular incident, those are very common when we're seeing that type of trauma. And so I would just do a little bit more imaging just to make sure that we don't have that. But other than that, we don't have any other differential diagnosis. We do, however, have some potential treatments that I want to go over. So we've got the fixation, we've got the cystotomy, and we've also got the urethra repair. Those are the 3 things that I wanted to go over there for the potential treatments. So next up, we're going to be asking a couple questions just in regards to the case study that I want to be able to answer here. So how does a pelvic fracture lead to a urethral rupture? This image, again, it is from the Georgia Health Sciences Institute. This is not regarding our patient, but it does a great job of showing how a urethra rupture can occur from a pelvic break. So basically what this is showing is whenever you have a pelvic break, there's a lot of this thin muscle that is lining this pelvic, that is lining the pelvis, and that it is very, very close in structure to our urethra. And so when you have that pelvis that is breaking and moving, it's taking some of that muscle with it. When that muscle gets up to the urethra is thin, it is not very tough. That muscle can rupture and completely, we don't have a complete tear, it's not completely severed, but I think this does a great job of showing how that occurs and how our injury for our patient could have occurred. Next up, we are going to be asking the question, what is the relationship between the fluid leaking into the perineal space and the butterfly hematoma? I picked this image. I know it's a very simple image, but I feel like it does a really good job of just giving us the reasoning for the shape. And if you think about the basic surface anatomy of someone whenever they're standing up, all of your fluid is going to be pulling down just based off of gravity. If you're looking at this superficial perineal space, that's basically the space that it's taking up here. Whenever that fluid, it's coming from back here, back behind your urethra and your bladder, it has nowhere else to go. So you're not only getting pooling from blood that has occurred from the trauma, but you're also potentially getting some of that leaking fluid from your bladder as well. And it is all pooling in that same place. And so I just felt like that was a really good image to explain that relationship there from our anatomy. I know we've done our surface anatomy, I know we've done our muscle anatomy, and I know we've done our bone anatomy, but I felt like this was a good way to kind of tie in all 3 of those to show that pulling there specifically. Next up, we're going to be asking the question, how to repair the urethra. And then I want to go ahead and make it clear that we're going to be doing this repair after we have done the life-threatening things first. So we'll have to fix our hip. We're going to have to fix those fractures in the pelvis. We're going to, sorry, not hip, the pelvis. We're going to have to do a little bit of measuring when it comes to the size of the tear. We're going to have to let the hematoma, we're going to have to let that subside a little bit before we can, really repair the urethra. We are already going to be having a cystostomy, which is, you can see here, our general cystostomy. This would be how we start putting a Foley in once we have our cystostomy, and that's to link those two together. Because if you tried to do a Foley just from the beginning without having anything to guide it, you would risk doing more damage. So that's why the cystostomy is so important to do first. We don't know, and I want to make it clear, we don't know yet if this would be the proper way to go about this yet, because we do not have the measurements for the tear in the urethra. The tear in the urethra is very important that we get a measurement here. 2 centimeters in a bulbular urethra or 1.5 centimeters in a penile urethra, that's going to need us to do a full reconstruction. This would not be applicable for this particular case. Next, we're going to move on to our complications. Our complications are erectile dysfunction, UTI, re-entry to the hospital from infection. Anytime you do any type of these, any type of grafting, even the procedure that we showed before the cystostomy, blood loss is always something that we're going to be worried about. And there's also some, so this particular study, this is not from our patient, this is from a mucosal graft study that was done in low-income countries. But I wanted to use this because I thought that it made such a through line for, from general studies that have to do with the urogenital tract to even, simple studies that we're having to do over here. They all have these same common things. So wound infection, UTI, pain, erectile dysfunction, problems with ejaculation. These are all common throughout anything that you're going to run into with the urogenital tract. So I wanted to bring that up. Next up, we have our risk factors for urinary incontinence, even with repairs. That's going to be things like stress, things like age. We're going to have to keep a check on his prostate. We're going to see if he's smoking. We're going to have to keep a check on his weight. All of these things will play a role in how his recovery is and how his incontinence is even after we have the structures repaired. And then next we just have our references. I'm not going to go over all of my references. I do just want to say that the National Medical Library was so incredible, all their resources. And it wasn't even just their resources, they were able to put me to other places. So if you have any questions, send them to Dr. Powell, and thank you so much.